Hello, I am Dr. Archit Patel, Associate Professor in Department of CVTS in UN Mehta Institute of Cardiology and Research Center, Ahmedabad. Today's topic will be on mitral stenosis. The points which we will cover are etiology, pathophysiology, diagnostic criteria, natural history, clinical features, and management. We need to understand the mitral valvular complex. The mitral valve consists of valve leaflets, the aortic leaflet, mural leaflet, the subvalvular apparatus, papillary muscles, tendinous cords, mitral aortic curtain, endocardium, left atrial myocardium, and the left ventricular myocardium. This is the diagrammatic representation of mitral valve, the AML and PML, and its relation with the left circumflex artery, the coronary sinus, the aortic valve, the left trigone, right trigone. In the figure on the right, we see the subvalvular apparatus. The primary chordae is attached to the free margin of the leaflet. Secondary chordae is attached to the left ventricular surface of the body, and the tertiary chordae is attached to the ventricular surface of the leaflet base. What exactly is mitral stenosis? Mitral stenosis is narrowing of the valve orifice to such an extent that causes obstruction of blood from left atrium to the left ventricle. The etiological factors which play important role in MS in India is most common rheumatic heart disease with male is to female ratio of 1:2. Other etiological factors are congenital MS, annular calcification, prostatic valve calcification, infective endocarditis, SLE, carcinoid syndrome, and LA myxoma. What happens in MS? Commissural fusion, varying degrees of leaflet thickening, particularly at free edges, and the site of fusion along with fibrin debris over the free margin of the leaflet. The chorda becomes shortened, fused, thickened. The left atrium enlarges with wall thickened but with preserved systolic and diastolic function in the early stages. Pathophysiology. Narrowing of the mitral valve causes volume and pressure overload of LA, which increases pulmonary pressure, resulting in pulmonary congestion. The pulmonary arterial constriction, interstitial edema in the pulmonary vessels, organic obliterative changes in the pulmonary vascular bed lead to right heart failure, RV enlargement, secondary TR, and PR. Decreased blood flow also decreases cardiac output, decreased left ventricular end diastolic volume and pressure with reduced stroke volume, which results in left ventricular atrophy. Left ventricular systolic function is usually well preserved. Pulmonary vascular resistance increases in patient of MS due to back pressure changes, but at times this is out of proportion increase in PVR due to reflex spasm of pulmonary arterioles as a result of left atrial hypertension. This leads to further aggravation of pH and RV pressure, leading to RV hypertrophy and secondary TR. What is the effect of AF in MS? Structural changes due to electrophysiological properties of left atrium, fibrosis of the internodal and interatrial tracts, increased chances of thrombus formation, and systemic thromboembolism. In cases of AF with fast ventricular rate, loss of effective atrial contraction and increased ventricular rate causes reduced diastolic filling time with impaired LV filling and decreased cardiac output. AF is most common in patients with MS with an increased prevalence with age. In patients with severe MS younger than 30 years, only about 10% are in AF, as patients with 50% of in AF who are older than 50 years of age. What are the diagnostic criteria for mitral stenosis? Mitral valve normal orifice in adult is 4 to 5 cm square. Most symptomatic patients have orifice area less than 2.5 cm square. The diastolic transmitral gradient is the fundamental physiological expression of mitral stenosis. At any given orifice, the transmitral gradient is a function of square of the transverse flow rate and diastolic filling time. As heart rate increases, During atrial fibrillation, for example, diastolic filling time is greatly reduced, thereby increasing the gradient and left atrial pressure. This is a table showing classification of mitral stenosis severity into mild, moderate, severe with specific and supportive findings. The specific findings are valve area in centimeter square, mild more than 1.5, moderate 1 to 1.5 and severe less than 1. With supportive, mean gradient less than 5, moderate 5 to 10, severe more than 10. With pulmonary artery pressure less than 30, mild, moderate 30 to 50, severe more than 50. Natural history of mitral stenosis. The average age of initial attack of rheumatic fever is 12 years. Average age of clinical sign is 20 and the average age for onset of symptoms is 31. Progression of valvular fibrosis and calcification is related in part to repeated episodes of rheumatic fever, but mechanical trauma and deposition of platelets and other blood substances resulting from stenosis-induced alterations of flow patterns also play a role. Most patients with MS have normal LV wall thickness, volume, and systolic and diastolic function, but do not increase cardiac output under stress, such as when LV afterload is acutely reduced by infusion of sodium nitroprusside. This finding suggests that the major cause of chronically reduced cardiac output in this patient is obstruction at the mitral valve. The average age of patient with surgically untreated stenosis is estimated to be 40 to 50 years of death. AF usually develops, often occurring first in paroxysmal form. Although originally incited by left atrial hypertension and hypertrophy, atrial fibrillation eventually becomes persistent because of disintegration of the architecture of the atrial muscles. It is an incremental risk factor for premature death of these patients. In a study by Olson, he found that 10 and 20 years survival in patients with AF was 25 and 10% respectively, whereas in patients in sinus rhythm at the initial observation, survival was 46 and 29% respectively. Systemic arterial embolization, most of which lodge in cerebral arteries, can suddenly complicate or kill the patients with mitral stenosis. Most emboli originate in the left atrial appendage or left atrium, yet often no residual thrombus remains in the heart after embolization. Left atrial thrombosis and embolization are much more common when AF is present than in patients with sinus rhythm. At least 10% of surgically untreated patients develop arterial embolization during their lifetime, and a massive cerebral embolus may suddenly kill a mildly symptomatic patient. Massive pulmonary hemorrhage may occasionally develop in patients otherwise mildly symptomatic from MS. The end stage of disease in many patients is characterized by cardiac cachexia, a state infrequently seen before diuretic therapy came available. The course of the disease varies because the increased lifespan due to surgery now results in development of hemodynamically important rheumatic aortic valve disease and important tricuspid regurgitation in a considerably greater population of patients with mitral stenosis. Symptoms. The patients of mitral stenosis experience symptoms of atrial fibrillation and pulmonary hypertension. Atrial fibrillation may cause symptoms of palpitation, systemic emboli. Pulmonary hypertension causes dyspnea, recurrent pulmonary infection, hemoptysis, cough, right heart failure, fatigue. The symptoms we'll discuss in short. Due to increased LA pressure, pulmonary congestion, dyspnea, orthopnea, hemoptysis, pulmonary edema. Due to LA enlargement, patient may experience palpitation, atrial fibrillation. Due to PH, RV hypertrophy, RVA, patient may experience sudden chest pain. They have ascites, edema. Due to decreased cardiac output, easy fatigability and syncope. And cause of death is congestive heart failure, systemic embolism, pulmonary embolism and infection. Signs. On inspection, what can we see in patients of mitral stenosis? Mitral phases, pinkish purple patch on the cheeks plus peripheral sinuses in lips, tips, nose and cheeks. Mala flush, raised jugular venous pressure, ascites, pedal edema, and pedal edema usually develops when right heart failure develops. Palpitation, pulse, irregular. Left parasternal heave when IV hypertrophy develops, tapping apex, diastolic thrill, hepatomegaly in right heart failure. On auscultation, we have the following findings. First heart sound, loud, slightly delayed. Second, closely split with P2 accentuated. Opening snap due to forceful opening of mitral valve. As mitral stenosis progresses, mitral valve opens early in ventricular diastole. The time interval varies inversely with severity of MS. We find rumbling mid-diastolic low-pitch murmur with presystolic attenuation in mitral area in MS. Cardiac output when markedly reduced is no murmur is detected because of this is called as silent MS. Graham still murmur, high pitch diastolic decrescendo blowing murmur along the left sternal border. How will we investigate this patient primarily? By ECG, X-ray, 2D echo, cardiac cath and other investigations. ECG findings will suggest AF or sinus rhythm, left atrial enlargement, right axis deviation, right ventricular hypertrophy. P mitrale in lead 2 by FID, the P wave duration is more than 110 meters. In lead 1 biphasic P wave. Right ventricular hypertrophy and right axis deviation suggestive of severe PH. Right ventricular hypertrophy with MS is associated with high mortality and is considered as an indication of surgery. P pulmonale may develop in presence of severe PAH. Chest X-ray findings, left atrial enlargement, redistribution of venous and arterial flow to upper lobes, calcification of mitral valve, curly B lines, enlarged pulmonary artery, enlarged right ventricle. This is an X-ray showing various modes of left atrial enlargement causing widening of the coronary angle towards the right, inferior, posterior. In this X-ray, we see the curly B lines which can be seen through the arrows. Echocardiography remains the most investigated tool for mitral stenosis. It assesses the hemodynamic severity, mean gradient, mitral valve, pulmonary artery pressure, right ventricular size and function, valve morphology. It is usually used to assess this for BMV. Diagnosis and assessment of concomitant valvular lesions, re-evaluation of patients with known MS with changing symptoms or signs, follow-up of asymptomatic patients with moderate to severe MS. Various echographic assessment modes, M mode, 2D echo, Doppler and 3D echo. 2D echo findings like roughly we can say they find echogenicity of mitral valve, reduced diastolic exclusion of mitral leaflets, communal fusion, diastolic doming of EML into LV, reduction of mitral valve orifice. The various modes with mitral stenosis assessed is spirometry, pressure half time, dissolution time, continuity equation and PISA, with mitral valve area classified as mild, moderate, severe. This is a chart showing severity and according to the 2D echo findings. TEE, it provides greater detail than transthoracic echocardiography. LA is visualized better than TEE. LAA is completely seen in TEE only. TTE has sensitivity of catching LA clot or left atrial appendage clot of 59%, whereas TEE has almost 100% sensitivity. TEE is also required before BMV to evaluate mitral valve anatomy precisely. Assessment of mitral valve by Wilkins score, important for choice of intervention. Parameters assessed are valve mobility, thickening, calcification, subvalvular pathology. Each parameter has been given a score from 1 to 4. Total score is sum of 4 individual scores. Score less than or equal to 8 are excellent candidate for BMV, whereas score more than or equal to 12 are less likely to have satisfactory result. This is a chart showing Wilkins scoring system. 3D echo, which has higher accuracy than 2D echo, gives better information of commissural fusion and subvalvular involvement. Cardiac cath for confirmation and quantification of mitral valve obstruction, detection quantification of MR, detection of complications of MS, status of aortic valve, assessment of ventricular function and assessment of coronaries. Management. Secondary prevention of rheumatic fever, most common in India, with injectable penicillin or oral form penicillin, sulfadiazines or macrolide or azilide antibiotic for patients allergic to penicillin and sulfadiazine. Duration: rheumatic fever with carditis and residual heart disease 10 years or until patient is of 40 years of age. Rheumatic fever with carditis but no residual heart disease 10 years or until patient is 21 years of age. Rheumatic fever without carditis 5 years or until patient is 21 years of age. Pre-operative optimization of patients. If the patient is in AF, then we try to revert the patient in sinus rhythm or we control the ventricular rate with injectables, digoxin or in oral forms, calcium channel blockers, beta blockers, amiodarone or cardioversion. The anticoagulation treatment in the form of warfarin is administered with a target INR of 2 to 3, the indications of which are class 1, MS with AF, MS with prior embolic event and even in sinus rhythm, MS with left atrial thrombus, class 2 indication symptomatic severe MS with LA dimensions more than 55 mm by echo. If the patient is in right RVF, pulmonary hypertension and edema and oxygen, diuretic loop therapy, digoxin, morphine, vasodilators, inotropic agents, anodilators, and prophylaxis against rheumatic fever and infective endocarditis. Treatment may be in form of BMV, that is percutaneous balloon valvulotomy, indications of which are progressive deterioration despite medical treatment, suitable anatomy, no iliac clot, less MR or mild MR, patient symptomatic NYHA 2 to 4 with mitral valve area less than 1.5 cm square, asymptomatic patients with mitral valve area less than 1.5 cm square and PASP 50 mmHg at rest, 60 with exercise. Balloon valvulotomy, what happens usually? An hourglass shaped balloon, it is usually passed through the interatrial septum and the valve, it sits in between the valve and it opens, which opens the mitral valve. This decreases the transmitral gradient and increases mitral valve area. Patient can experience immediate symptomatic improvement, decrease in LA pressure and pulmonary vascular resistance, improved cardiac output and gradual reduction in pulmonary hypertension over months. Surgical correction is indicated in patients with MS. When patients with MS have acute rheumatic carditis, left atrial thrombus, extremely tight stenosis, heavy valvular calcification, restenosis, the surgical management will be in the form of open mitral commissurotomy or valve replacement. Approaches can be through median stenotomy, right or left thoracotomy or transverse thoracotomy. This is a diagrammatic representation of mitral commissurotomy where anterolateral and posterior mitral commissures valvulotomy commissurotomy is performed and the papillary muscles are divided. The other form of treatment is valve replacement, which is most widely performed, where valve is replaced with a biological valve or a mechanical valve. Thank you.